hopefully less than a half hour, I will record this as well. Okay. So in finishing up Chapter 30 content, remember we were talking about alterations of renal and urinary tract function in children. And remember I said that some of this isn't necessarily just pediatric in terms of the content. It certainly happens in the pediatric population, and so therefore it's good for us to talk about it in the pediatric population. But these things can certainly happen in the adult population as well, and what we're going to finish up, today's topics certainly could be, or specifically this one, vesicoureteral reflux, could certainly be in the adult population as well. So that's where we're going to start off with and pick up from. So this should go pretty quickly. Okay, so vesicoureteral reflux results basically from a congenital abnormality in the tunnel from where the ureter sort of comes into and sort of connects with the bladder. And so the reason we talk about it in the pediatric lens is because it usually is a congenital abnormality, meaning just from birth, just an abnormality structurally. So you'll start to see it as early on as in childhood, or maybe even earlier than childhood. But as you see here, VUR results from a congenital abnormality that is a short submucosal tunnel and ureter that permits reflux by the rising pressure of the filling bladder. Remember how I talked about that normally as the bladder gets more and more filled with liquid, it compresses that tip of the ureter that connects into the bladder and presses it off so that urine cannot go back up into the ureter and then sort of regurgitate and reflux back up into the kidney. So under normal circumstances, the pressure that mounts inside the bladder would shut that off and squeeze and compress those two tips of the ureters off. And in this case, the tips of the ureters are so small that they don't become compressed by the filling pressure. And so then what happens is you have a retrograde flow of urine back up from the bladder into the ureters. And we know, we've talked about this already, that reflux, or standing, urine, instead of it flowing normally from the kidneys into the ureters into the bladder, standing water, so to speak, or, refluxing urine, breeds infection. So reflux perpetuates infections by preventing the complete emptying of the bladder, and basically just provides a reservoir. Anytime you have that stagnant urine sitting there and sort of reaching back up into the kidneys, it's going to be a great breeding ground for infection, which quite commonly then leads to a kidney infection. And we know that sort of the scientific sort of clinical term for kidney infection is what? Pyelonephritis. Good. And so that's sort of the pathophysiology of VUR. And it's this combo of both the reflux and the infection that occurs in VUR that's sort of the important sort of cause and the important pathophysiology of pyelonephritis. Then what happens sort of chronically, if this continues to happen, which it certainly can, if this is an abnormality that's there from birth, it can be sort of a chronic problem. What happens is that renal tissue can actually get injured. Scar tissue can actually form. You can actually have sort of renal insufficiency, so it almost sort of begins to create sort of an intra-renal acute kidney injury because you're dilating and sort of putting such pressure and hypertension on the renal tubules themselves. And so this can happen many years later down the road, but it's certainly more of your sort of chronic symptomatology, your chronic manifestations of VUR in someone with these persistent reflux, persistent kidney infections, persistent stasis of that urine sitting there. You'll see sort of death, injury, scarring, those types of issues to the kidney tissue itself. So that's something to think about with VUR. That's a pretty certain, a certain sort of happening, so to speak, if it doesn't get taken care of and diagnosed early on. So early diagnosis and treatment in VUR certainly is very important because you'll see a lot of this chronic type of issues happen later on down the road, if not. So what does it look like? What does it mean for the patient with VUR? So it can be totally asymptomatic, and it can be asymptomatic for a long time. That's certainly something that's very common. But what you also may see, and what's also very common, is what we've kind of already talked about. Recurrent UTIs, unexplained fevers. So, obviously if you've got pyelonephritis, you're probably going to have a fever, if not a high sort of spiked fever. In children, you're going to see issues like poor growth and poor development because they just don't feel well. I mean, if you always have some sort of UTI and you're always having pain and you're always having fever, children are not going to be eating well and developing properly. So you see a lot of growth and development issues. And then obviously irritability and feeding problems as young as like in babies. Clearly, if babies or children don't feel well, they're not going to be eating well. You also might see a family history of this as well, sort of a congenital abnormality through the branches, if you will, of a family tree. The way they actually sort of definitively diagnose and really sort of know exactly what they're looking at is, and I said hopefully early, hopefully we sort of diagnose and we get answers early so that we totally prevent those chronic problems from occurring. But diagnosis is done by avoiding cystourethrogram, VCUG. And what that basically does, it's an ultrasound of the bladder while the person is actually voiding. So while they're actually urinating, or micturating, as we say in the clinical scientific world, they actually perform an ultrasound during urination. And then what they'll look at is specifically not only what it looks like while they're urinating, but then after the fact, they'll sort of look at is there a post-void volume. So is there a high post-void volume left in the bladder, or even left even higher up, like in the ureters. That would be a pretty good sign, pretty good indication that there's reflux going on. If you've got a lot of urine left sitting in the bladder and or ureters and or kidneys right after you're done urinating. That should be pretty emptied out. You should have pretty much zero volume after a proper urination. And if you've got a lot still sitting in there, that's a pretty good indication of reflux, of VUR. So what happens if we do? What if we get a high post-void volume? They're specifically diagnosed with VUR. Some children, especially sort of early on, again, if you're doing this diagnosis and you're sort of treating it early on, respond to really sort of non-operative management aimed at sort of just prevention and treatment of infections, recurrent infections that might occur. However, if this child or this, as they get older, young adult, so on and so forth, continues to have recurrent infections, recurrent problems, recurrent reflux, some sort of surgical intervention may be required. And the reason is, and let me sort of show you here what the issue sort of structurally is. So the way that the ureter attaches into the bladder, normally, they're sort of like this tube, essentially. So once it enters in through the submucosal sort of lining of the bladder, it continues on. So that, several centimeters, if you will, of the ureter actually sticks past the submucosal sort of lining of the bladder far into the bladder. Again, because this is the section right here that's sort of grayed out. This is the section that would sort of get compressed and pinched during high pressure in the bladder to make sure that reflux doesn't occur. Well, look what happens in someone with the structural defects of VUR. Look how much shorter their ureter is as compared to how much farther the normal ureter will sort of go down into the lumen of the bladder. So it's much shorter, and therefore it doesn't necessarily get pinched. It doesn't necessarily get compressed the way this part of the ureter would under normal circumstances, which makes perfect sense then that the urine just flows right back up. Why not, right? And that's exactly what happens structurally with VUR. And so really, if you look at it, a refluxing ureter, a ureter that's sort of part of this VUR, has the exact same anatomical features of a normal ureter. It's just shorter, right? And therefore it doesn't get compressed. And that's the major issue. Okay? Any questions about that? This is a really good picture of the different grades. So remember how I said some people may be completely asymptomatic, some people may have recurrent chronic infections that cause chronic sort of kidney injury. Here's why. Because depending on the structural abnormality of that part of the ureter that does or does not stick down into the lumen of the bladder, you get a certain degree or a certain degrade of how much of reflux actually goes back up. So here in grade 1 you see that here's the full bladder. It just kind of starts to go back up the ureter. Here it goes all the way back up the ureter. This little structure here just kind of shows you the beginning of that renal pelvis, that part of the ureter that actually kind of is part of the kidney. And here you start to see in grade 3, not only does it go back up into the renal pelvis, it actually starts to kind of balloon out and dilate those structures. This is where we're talking about major issues with tubule problems, issues with filtration, those types of things. And then look at grade 4 and grade 5, how blown out and sort of dilated the ureter is and the kidney is. So you can imagine if this is the way that the ureter and the renal pelvis inside the kidney looks, we're having major sort of like acute kidney injury, right? Lack of filtration, lack of proper tubule function because of how much urine is just sitting there and preventing proper flow, proper filtration, proper absorption in that area. So I think this is a really good illustration of those difficulties in terms of the different grades. But it really just does depend on how far the reflux goes up the ureter or goes up into the kidneys and how much dilation occurs depending on how symptomatic and how many sort of issues this person might have. So, any questions about VUR before we move on to the last few slides? Again, pretty straightforward. It's a pretty clear, easy to visualize structural abnormality, but I just want to drive home the importance of the structural abnormality with the actual internal kidney injury and kidney damage that can be done. Depending on how bad that reflux is. So, okay, good. All right, this slide we'll honestly not spend a lot of time on. We talked about it a little bit when we talked about cancer and oncology last semester, but I just wanted to briefly touch on it because it is something that is certainly part of the pediatric, conversation when you're talking about renal function and renal structure. So, Wilms tumor. Or nephroblastoma, you'll hear it referred to as both, is an embryonal tumor of the kidney. And remember what I said, what embryonal tumors are? Anybody remember what I talked about that with sort of the pediatric population in oncology? Yeah, it starts from the very primitive stem cell embryonic cells inside the developing fetus. So oftentimes these tumors are present at birth. They may not necessarily know they're present at birth, but very quickly thereafter, they'll start to see issues, they'll start to see manifestations, and it's a pretty sort of primitive stem cell-based tumor. So again, arises from the proliferation of abnormal renal stem cells in this specific case. Now again, you might see this recur in a family tree, which is the inherited form, or it just can be completely bad luck, just a sporadic form that just this one in particular, baby in this family has a development of nephroblastoma. It can be asymptomatic, or it can present with sort of vague abdominal pain, which again, pretty hard for a baby, pretty hard for a neonate to sort of tell you that they're having vague abdominal pain, or even for an infant or a small child. So sometimes you'll look more at things like hematuria, fever, and hypertension, because you can actually have sort of the normal issues with the kidney, proper functioning of the kidney, the same way you would with any other issue going on with the renal tissue. So you can see hypertension in these babies and infants and small children. But usually a lot of these things are kind of vague and not super easy to sort of come about or sort of know that they're there. So quite often what you'll see is that the parent is actually the one that kind of notices something abnormal. And when they're changing a diaper or they're giving a bath or whatever it may be, they notice sort of this hard abdominal mass or this abdominal swelling that really starts to, clearly scare them and goes for medical sort of assistance at that point. So sometimes it's not until the tumor gets pretty big that they actually notice and sort of seek attention. Diagnosis is made obviously by radiological studies, so looking at ultrasound, CAT scan, those types of things. And treatment, again, sort of is a combination of things depending on the extent of the tumor, depending on, how large it is, has it grown to other places, has it spread, those types of things. But a combination of, obviously, surgical resection, just removing it, chemo, radiation, and then, like I said, a combination of these things. But treatment certainly depends on the staging. And again, I just wanted to sort of quickly touch on that. Okay. The biggest thing with this is not only are you going to see sort of the cancer type symptoms, but you're also going to see some of those renal failure type symptoms, because the major issues here, especially like it's causing like hypertension and things like that, are issues because of the glomerulus, right? Because of the glomerulus, the nephron, the tubules, those types of things actually causes filtration problems. So you're seeing sort of oncology type symptoms with the renal symptoms that we've already talked so much about. So again, short and sweet, but just wanted to sort of touch on that since we're in the pediatric realm today. All right. Any questions about that? Yeah. Mm-hmm. Yes. He asked, would you see kind of the typical presentation of like an intrarenal kidney injury? Yeah, you would. So you'd see lab abnormalities like high BUN, high creatinine. Again, because we're talking about specifically damage that could be done or pressure that could be put on structures because of this mass. So you're going to see issues with the integrity of the nephron, of the glomerulus, of the tubule. So you're going to see intrarenal kind of symptomatology on top of the oncology stuff. Right. It would depend. It would depend on what their systemic sort of symptoms look like. Oftentimes, because this is a structural sort of tumor, and if it's pretty straightforward and it hasn't spread or the staging is pretty low, a simple resection of the tumor out of that, out of that tissue can certainly help with all of those things. Yeah, good question though. All right. Any other questions about Wilms tumor, nephroblastoma? Okay. And then the last two slides, really quick, really easy. Again, we're talking about pediatric population, so we can't not talk about sort of incontinence, enuresis, those types of issues. So enuresis or incontinence is basically the involuntary passage of urine by a child who's beyond basically potty training age. So who's sort of past that age of the normal sort of developmental stage, which is about 4 to 5 years old, when voluntary bladder control should be obtained, should be pretty clearly potty trained by 5 years old. So this is a child who isn't, who is incontinent past the age of 4 to 5. Now you could see either primary enuresis, so this is a child who, let's say, is 5, who's never been potty trained, who's never been able to sort of achieve continence. Or you could see secondary enuresis, and that's a child who's been potty trained, who's had continence for at least 6 months or so, and then begins sort of wetting again. So they're sort of, presenting these signs and symptoms of wetting, not necessarily wetting the bed, because that's normal until like the age of like 7 or 8. Usually, under normal circumstances, if there isn't some other type of neurological thing going on. But certainly just, lacking potty training skills after they've had them for 6 months or so. And again, you can have daytime enuresis or nighttime enuresis. Again, nighttime enuresis being less worrisome, being less of an issue, because as my pediatrician has told me before, they literally do not worry about it until the child is 7 or 8. In terms of needing to wear a pull-up or having bedwetting or things like that. So we're more concerned about the daytime enuresis than the nighttime enuresis. Okay? The pathophysiology is not completely understood, both for primary and or secondary, of why someone would never, why a child would not achieve continence by 5, or would and then have sort of lost it again. But there's a lot of different theories. A lot of different sort of reasons, or maybe a combination of reasons that might cause this. So some of the things would be sort of like organic causes. So maybe UTI, maybe constipation. So oftentimes if the child's doing a lot of straining or is feeling constipated, they might have some sort of lack of continence or loss of urine during straining or during sort of that uncomfortable sort of abdominal pressure sensation. Or there's something maybe neurological going on. So those would be some of your sort of organic causes. Factors that would increase urine production. What do you think would be some things organically that would increase urine production in children? Mm-hmm. Okay. Okay. Maybe there is some sort of hormonal issue. Along sort of the hormone endocrine thing, I would also add a sort of new diagnosis of type 1 diabetes, right? We know that they have a lot of polyuria experiences in type 1 diabetes. So perhaps if there's a child who has, now all of a sudden started to have issues with enuresis, let's look at, are they feeling okay? Is this maybe a diabetic type of thing? And then there could be sort of simple factors like not letting the kid drink too much water right before bed, sort of simple factors like that. There could be some sort of developmental sort of maturational lag. There could be some genetic factors that could certainly play a part into that. Sleep patterns. So if the kid is a really heavy sleeper, or they're very difficult to arouse, or they've got some sort of sleep obstruction, like a sleep apnea or something like that, where they sort of have more pathologic sleep to start with, they might have more issues with nighttime enuresis. And then psychosocial theories. So psychosocial theories oftentimes result in sort of circle around big life changes for a child. So that could be something as sort of benign and sort of happy as a new sibling or a move or a new school or, something like that. Or something certainly more concerning like abuse or trauma in the home or, those types of behavioral types of things that you're now starting to see in these children who normally don't have these issues. So again, psychosocial theories both on sort of the positive spectrum and then sort of the more negative, worrisome spectrum as well. And then treatment, obviously, educate on the etiology, so try to get to the bottom of what some of these theories might be for this particular child. There are certainly things like behavioral therapy, and then obviously treatment of the organic problems. So is it a fluid management problem? Is it treatment of constipation? Does this child have UTI? Is this child perhaps a new onset type 1 diabetic? Those types of things. But again, it can be pretty complicated, and it can take a long time to get these things sort of sorted out. And so that's why I just wanted to kind of briefly touch on it today, because it is certainly a common issue and a common problem in the pediatric population. So just wanted to kind of quickly mention it today at the end. Any questions or any issues about enuresis before we finish up today's lecture? Pretty straightforward. Yeah. Mm-hmm.
Is there a tie between ADHD children and
Could be. Yeah. There's a lot of sort of not only developmental but also sort of psychosocial, things that could certainly be a part of that. Absolutely. And I would certainly include that into some of the organic causes. Yeah. Mm-hmm. Yeah, absolutely. Good question. Any other questions? All right. Like I said, that was quick. I just wanted to make sure we had time to go over it together.